Hello, and welcome to this video where we will explore how a septoplasty is performed. My name is Stephen Hauser. I am an otolaryngologist, specifically a rhinologist allergist in practice in Cleveland, Ohio. This coronal CAT scan image depicts a very severe septal deviation towards the patient's left side, as well as maxillary sinus atelectasis. And this CAT scan demonstrates a more moderate deviation towards the patient's right side, and this CAT scan image actually depicts some of the clinical video that we have showing a patient's surgery, as we're seeing right here. This is a view of the patient's nasal cavity before we've operated. On the left side, you see kind of a dimple towards the septum inferiorly, and on the right side, opposite that dimple, we have a very significant septal spur that pokes out into the side wall of the nasal cavity. We'll tend to approach the patient's septum from the more concave side, which in this images then would be from the patient's left side. And here we are injecting the patient's septum, typically taking the needle and actually passing it into the cartilage slightly, and then backing it out as applying pressure to the plunger to allow the injection to find a submucoperitoneal plane and dissect along the tissue and perform some hydrodissection for us. The incision for the septoplasty will be made 2 to 3 millimeters lateral to the free edge of the caudal aspect of the septum, and this allows us to then identify the proper plane in a submucoperitoneal area to then elevate the mucosa carefully to allow us to insert a speculum. The mucosa tends to be fairly tightly adherent in the anterior aspect of the nasal cavity, and we will utilize first a caudal knife to identify a good plane to dissect, and then after that we'll utilize a caudal elevator, the sharp end of the caudal elevator, in an effort to create a pocket so that we can pass a short speculum into this area, and then we'll utilize the blunt end of the caudal elevator over the bone and back, as the mucosa here there tends to elevate fairly readily. Once we have achieved a pocket in the anterior aspect of the septum, we can then introduce a short speculum to allow us to visualize within the nasal cavity below our flap to help guide our dissection, both traveling superiorly as well as inferiorly, elevating the mucosa as we go, working our way slowly deeper within the nasal cavity. We can switch to a longer speculum as we get deeper within the nasal cavity so that we can elevate the mucosa all through the nose. I typically perform septoplasty with a headlight, though for the purpose of education here we have an endoscopic view showing exactly what takes place below the mucosal flaps. This is dissection from the patient's right side, so their septal cartilage, which is soft but more firm than the mucosa, is on the right side of the screen, whereas the mucosa that we're elevating away from the cartilage is on the left side of the screen. And this is a caudal elevator at sharp end, moving the mucosa away, and you see there's not much blood flow in this area as we are in an appropriate submucoperitoneal plane. This diagram will depict what is taking place at the septum itself. We will start with an incision at the caudal aspect of the septum, approximately a centimeter back, and then dorsal incision as well, halfway through the cartilage that will be completed with the caudal elevator. We'll cut the bone superiorly, and we will remove the cartilage posterior to the L struts so that we can better expose this bone beyond. We will remove the deviated bone and we will not have any rocking motion at the cribriform plate area to keep the patient completely safe. On the patient's left side, here we will see an L strut utilizing the chyle elevator to elevate the mucosa. You can see that cuts in the dorsal area here, cut all the way back to bone, and then the caudal cut, cutting down to the floor of the nasal cavity. In order to elevate the mucosa on the other side of the cartilage from where we have been working, what I often tend to do is actually flex the anterior cut with my thumb while I utilize instruments to go through the caudal incision that I've made in the cartilage, and this tends to allow us to enter into a nice plane so that we do not disturb and go through the mucosa on the opposite side of where we have been working. And here we have an endoscopic view of elevating the mucosa off of the opposite side from where we had been raising the mucosa, so as to isolate the cartilage behind the L strut, so we will be able to remove this tissue, which is typically deflected, and as well better expose the bone beyond it. The cartilage had been cut only halfway through, and the chyle elevator was used to complete that cut, as well as to separate the cartilage away from the bone beyond and the floor, and we then can remove the anterior aspect of cartilage to better expose the bone beyond. Double action scissors will be used to cut the bony septum superiorly, and then the deviated bone below this will be removed, typically in a piecemeal fashion, utilizing grasping forceps as well as through cutting forceps, as depicted in this still image. After removal of deviated bone, the removed cartilage will be morselized or flattened out and returned to the septal flap to provide stability of the patient's septum, as well to help prevent any potential perforation that might occur. We will then inspect the nasal cavity to ensure that we have the septum straightened out. In this case, the patient has had sinus surgery as well, and you saw gel film roll up above. This patient had a very prominent spur towards the right side, and therefore they do have a tear at the apex of that spur, which is completely expected. We're very careful then to make sure our flap on the opposite side is completely intact and that there is no tear, so as to avoid any perforation. The hemitranssection incision is closed with several interrupted chromic resorbable sutures, and then dural splints will be placed on each side to ensure the patient's septum will heal quite nicely. Thank you for watching.